So here we are at the beginning of another day, and I get this opportunity to start everybody off with a very serious topic. And so bear with me, and we'll definitely go through the ups and the downs of that. Yeah, so I'm going to be speaking about hospice, and I'm specifically going to be focusing it on hospice for dementia so that we keep this focus very clear. I am a family doctor originally by training, and I have been doing hospice care now with one of our local hospices here, Ambercare Hospice, for the last 12 and a bit years. And so I feel like I have quite a bit of knowledge about that, but I'm always learning more, always. So yeah, the ups and downs are, even at the end of life, we see a lot of that. Not always a downer. Can be very enlightening, very positive and inspirational. Absolutely. So as a family doctor, I quit doing family practice, as I say, about 12 years ago. And since then, I've many times had people who, my patients, families, people walk up to me in a store or on the street and say, "Hey, Dr. Thron, are you still taking any new patients?" And I sort of pause for a minute and I say, "Yes, I'm definitely taking new patients, but you'd have to be dying to see me." So, right? And you might think that's the bad news, but here's the other hand of that. Well, I took care of this woman who was in her 90s, and when we brought her onto hospice, she was so intrigued with all the things that hospice had to offer. She was fantastic. And she called all of her friends after we did the admission process and explained all the hospice benefits and things. And she called all her friends and said, "I just signed up for the best health insurance I have ever had." And as I explain this, I think you'll really believe that too, which is part of why my overall thinking about where we should be going with medicine is that we should base all of medicine on how we do hospice care. So, think about that as we move through this conversation. So, obviously humans, we've been taking care of our loved ones in the dying process for forever, right? As long as we've been around, because, in the most basic way, dying is just as much part of living as being born into living. So that's just the deal. And it's not really until very much modern times that we have called it hospice, and we've done this sort of formalized thing around it. In 1967, I believe, Dame Cecily Saunders in England was the first one who really said, we need a specific home-like environment for people who are dying to really be able to address all of their needs. Her basic philosophy was, you matter because you are you, and you matter to the last moment of your life. And that's just really so beautiful, so simple, so beautiful, so true, whether you have dementia or whether you have any other illness, or even no matter what your life has looked like before that point, right? So she set that up, St. Christopher's Hospice House. She came to the United States. She was talking to people, inspiring nurses, and in the 70s, hospices started to form up because nurses wanted to go into people's homes and really take care of them with that philosophy in mind. And then in a really, I sort of blows my mind still when I think about Medicare actually having this level of wisdom to put into place the hospice benefit. When they carved that out and made that a formal and permanent part of Medicare in 1986. So recent, really, in perspective there, that we've had the hospice benefit. It is sort of a carve out of the basic Medicare. So if you have Medicare Part A, you qualify for having hospice benefit as a free benefit. And so I'm going to review that a little bit more about what all does that include. It is really an amazingly comprehensive, thoughtful program that addresses the needs of people and their loved ones, their caregivers at the end of life. It provides a team of caregivers that includes everything from volunteers, social workers, chaplains, nurses, home health aides, and a doctor. You mean, you think about, ask yourself, does your insurance offer you that on a 24/7 basis? And could you occasionally have used any one or all of those things, or your people, the people that you've loved and taken care of? So it's, all those things are provided in the setting of your choice. Generally speaking, that can be in your home, that can be in a nursing home, in an ALF, so an assisted living facility. That can be, we've taken care of people in hotel rooms, sometimes even in their cars, although we usually try and help them facilitate some other living situation if that's the case. But it's really so versatile in that sense about where you can receive this level of care. It includes the medicines to help manage symptoms at the end of life. It includes access to, so we can provide the durable medical equipment. That's all the hard things like the beds and the wheelchairs and the walkers and those kind of things. It also includes the soft things, if you like, the wipes and the chucks, the pads that lie under somebody if they need to, if they're bedbound or incontinent, the pull-ups. All of those things are also included. So it's a 24/7 access to a nurse who can not only answer calls and talk somebody through things, but can show up in the home and really guide somebody and give that level of support, so that it can be really emotional support as well as sometimes the physical needs that may be happening. The social workers provide a level of attention to, counseling and really assisting people in their grief process, in their wherever they're at in that process, but also in really helping facilitate the needs that are in the community that maybe people have in terms of getting more caregiving into the home, or the need maybe to place somebody into a facility where they can receive the level of care that they need. So the beauty of this kind of a hospice approach is that we are really addressing the needs of the whole person. Not only are we addressing the needs of the whole person in terms of physical, mental, psychological, spiritual levels, but also the needs of the family and caregivers around them in terms of those things as well. The other pieces that I didn't mention, I'm sorry about that, in terms of the team, is a bereavement coordinator, a bereavement uh, system process by which people, the loved ones of somebody who has died in our care, can then receive bereavement counseling for 13 months after that death has occurred. And that, that's an incredible piece of wisdom on the part of the Medicare people who planned that out, because as we know, and I know many people have talked about, addressed that process, the cycle, and as Hope and other people are going to be speaking about more just after I finish this, is really, the bereavement process is huge, and it needs to be addressed through at least a whole cycle of a year's time to really have the full benefit of that. And so I think that, again, is just this incredible wisdom in terms of how this has been set up. So what do you think? That's a pretty good deal, right? To get that kind of insurance, all those things available to you at no out-of-pocket cost to you if you have Medicare Part A. Yeah, I mean, who wouldn't want that, right? And yet hospice gets a bad rap, right? So, and it gets a bad rap, of course, because it's associated with this one thing, that it means somebody is going to die. And in our culture particularly, we're just not so very comfortable, despite, many years now of people really saying, we need to talk about this, we need to think about these things, and really trying to push this conversation forward. So, it's still an issue, right? We still do. We have trouble accepting that death is part of our natural life cycle. And so hospice is often sort of maligned and, frowned on. Sometimes we have people who, they need our services badly, but they have not been able to wrap their brain around that that's what's actually happening for them. And so we just have to wait that out. Not everybody dies with the benefit of hospice, but I wish that everybody could have all those benefits, the people to support them in the ways that we see really make a difference. Not everybody chooses that, and I certainly honor that. Everybody has to make difficult choices, you know, all the way through our lives. We do, and certainly at the end of our lives. And we've had family members where they say, I have to do everything possible to keep my mother alive because that's the only way I know, you know, that's what she wanted. And that's what I need to do in order to know that I have really fulfilled her expectations of me. And we honor that, of course. So hospice can take place in a hospital setting. It is a very specific piece of that, general inpatient placement for hospice. It can happen, as I say, in all these other places. It can happen as a respite. Somebody, say, is at home and they are being cared for there by their home caregivers, but the caregivers need a break. And when it's not in pandemic times, we can almost always find a 5-day respite stay in one of the nursing homes for somebody, and really allow the family to have a full break in that way and know that they are well supported in their care for their loved one. So yeah, and I'm sure I haven't even addressed all the things. I mean, you know, the hospice benefit really does, I think, address. And if you have any questions specifically about that, then please, you know, just ask those things, and I'll follow up with that at the end here. The main thing, though, that happens is that, you know, you qualify for the hospice benefit in Medicare, and not just Medicare. Every other insurance pretty much has followed suit in terms of trying to make sure that uh, you can get those services. But some insurances do have a copay that goes with it, for example, that most hospices, I think, can waive if that's, you know, just not doable for a patient at that time. So the other piece, though, is not just, you know, one, is the patient mentally and ready, and the family is ready, but also, do they meet certain guidelines or certain criteria that Medicare has spelled out? They are not absolute criteria, even though we speak of them that way. They are really guidelines, and they are disease specific generally. So we have guidelines for heart disease and COPD, and so, you know, and so on and so on. And specifically for dementia is what I'm going to be addressing also. But in a general way, we look at this criteria. We, you know, two doctors pretty much have to agree that if we stopped intervening in a disease process, the natural course of that disease would mean that somebody would die within 6 months' time. Well, you know, I actually think doctors are the worst with their crystal balls, probably because we don't dust them off very often, I think, you know, but crystal balls are just notoriously bad when it comes to this. So we do our best and we say, yeah, you know, we have certain things, prognostication, you know, it's a whole art to it, to be able to predict what the future holds in terms of with certain criteria. And we have some tools that allow us to make some predictions, but all of those tools fail in light of the individual that sits in front of us, right? Because we don't know all the specifics, right? To the known and the unknown variables of any one given individual, and what they might bring to the table, and how long they might be able to work with what's going on in their body or their minds, right? So, but that's sort of the basis of it, right? If this disease process were to progress without us intervening, would it result in somebody dying in 6 months' time? Sometimes we use the simple question of, would it surprise me if this person was dead in 6 months? And I honestly, I mean, that's a question that's not, doesn't take a, you know, a doctor trained mind to ask yourself. If you've been watching somebody who you know, love, and care for declining, you can often see the progression of disease in a way that tells you that things are not going well. So it doesn't, that piece does not really require, you know, all the training that I've been through for that, but it's a very helpful tool in a general way. And I often find myself asking the nurses who go out and do the evaluation and do the admissions in that sense, so sort of that question. Well, would it surprise you? That's sort of the take of, what's your gut feeling about this, right? And that, I think that can be a helpful way, because, well, we just don't have exact numbers to tell us how this is going to go otherwise. So in the talk that I did on Monday, I talked about dementias and neurocognitive decline as a way to phrase that. And I'm just going to recap that by way of saying that, we define dementia by saying it's a slowly progressive decline of the brain function that interferes with the activities of daily living and the capacity to carry those out. We have myriad, so many different kinds of disease processes that can happen, that can affect the brain in all the different places that it may start, in the course of it, the patterns of progression that happen. But it seems that for all of these progressive neurocognitive disorders, there tends to be a final common pathway. In other words, if somebody has started with Alzheimer's dementia or vascular dementia or Parkinson's disease related dementia, it still ultimately comes down to this, right? They have lost their capacity to communicate effectively, to manage their activities of daily living. That means to cook for themselves, provide for themselves, to toilet themselves and ambulate and so on, right? And this progression happens. It doesn't always happen in the same sequence, but ultimately you follow a similar pathway. So a final common pathway in that sense. For all we speak about, living with dementia, and of course, people live with dementia and live very beautifully with dementia. Susan, you so inspired me when you spoke about your process. I can't even tell you. But it is a life-limiting disease, right? We know that there is a course that happens, even though it may be quite long, of time in which you no longer have the same prognosis that you did before, where your life expectancy might have been in the, for most of us in the United States, we're in the 80s somewhere, that we can hope to live relatively healthy lives until then, probably with some amount of chronic disease process, but not necessarily with one that is life-limiting. But dementia is a life-limiting disease. Generally speaking, and they can be, the disease processes even for the dementias are so different that we have to take that into consideration for when we're thinking about hospice. So for example, an Alzheimer's dementia might have a prognosis in this very broad range of somewhere between 6 and 12 years, let's say approximately. And, somebody who has a diagnosis of ALS, for example, might have a prognosis of more 2 to 5 years. So from a hospice perspective, where we're looking at trying to, refine that even more and say, okay, it's not just about having a life-limiting diagnosis, but really, what do we understand about the process and where somebody is now and how they then look to qualify for hospice? Again, sort of with the general idea that we're looking at somebody's lifespan being more in the 6-month range. And so one of the tools, again, all those variables that we can't account for, but there are a number of variables that we can look at. And so we try and do that. We use one of the tools, I spoke a little bit about that on Monday also, that has been tested, validated, and used for Alzheimer's dementia, and that's the FAST scale, or a functional assessment tool. And it helps us to categorize Alzheimer's dementia into stages. And, from the first one, where we're all totally capable, although sometimes I wonder if I'm totally capable of managing my own life, but let's just say, that theoretically I could do that, to all the way down to needing assistance with everything, right? Not being able to roll over in bed, not being able to feed oneself. So it moves through the progression of that. This is just an example. Stage 6, for example, would include not being able to dress oneself appropriately, not being able to bathe appropriately, not handling the mechanics of toileting, still may be continent with assistance to handle the mechanics, and then ultimately urinary incontinence and fecal incontinence. And stage 7, the last stage of dementia, begins by already knowing that the ones from the previous stage are in existence, and then adds to that, not speaking less than 6 meaningful words in a day. Those can be the same words, that can be a whole lot of words that don't necessarily have meaning or communicate effectively. Then goes to stage 7B, which is really being able to speak about one single intelligible word in a day. 7C, somebody who's become non-ambulatory. They can no longer walk, not even with assistance. 7D, they lose control of their core muscles. They need support to be able to hold themselves up even in a sitting position. And 70E is not able to smile or even engage in that way. And 7F, no longer being able to hold one's head up. Now, a lot of other things can happen in that time frame also, and commonly do, where somebody is not able to feed themselves, where they may have more difficulty being able to coordinate the effort to swallow appropriately and to, yeah, engage in other ways. There may be combative behaviors. There may be a whole variety of things that can go along with that. So when we're assessing somebody for hospice care, we are looking for where do they fall on that. And we, as I said on Monday, we use this even though it's not appropriate for other forms of dementia, because the sequencing of how those things happen does not necessarily happen that way for other forms of dementia as it does in Alzheimer's. But nonetheless, as a ballpark way for us to understand where somebody is at in their dementia, is a tool. We're not using it quite appropriately, but I still find it relatively helpful. And so we look not only for those and where somebody is in the stages of that, but also what other things are going on? What other kinds of illnesses do they have? How far along in maybe heart disease or their COPD, or if they've just been losing weight. Even though sometimes in dementia, when somebody starts getting fed, they can be being fed a large volume of food and still be losing weight rapidly. And so weight loss is one of the factors that we definitely factor in. Not being able to swallow with ease or pocketing food as it's coming in. Those are all things that we consider that suggest that the disease process is farther along. So that's the basic overview of how we assess that. So somebody has to be usually at a 7A or beyond for us to take them onto hospice, unless they also have a lot of other things going on. Or I sometimes say, if their decline has been so rapid in recent time. So they've been going along pretty well, slow decline. And all of a sudden in a 2-month time period, they lose 10 pounds and now they're pocketing their food and they're stumbling when they walk. Sometimes with that kind of rapid decline, I'll also say, let's bring them on. So that's the overview of what hospice, what sort of the criteria are, if you like, or the guidelines. So the good news, by the time somebody gets to that place in dementia, many is the family who is working so hard, really struggling in a lot of ways to manage the caregiving for somebody like that. Not always. Man, I have seen families that do it so beautifully and just seem to do it effortlessly. I'm always in awe of that. But often people feel like they're ready well before that to have some extra assistance and certainly some caregiving or at least home health aides that could come and help manage the incontinence and the bathing and things like that. So often people ask us to come and evaluate somebody for dementia, coming on hospice well before they meet those criteria. But because especially the Alzheimer's dementia, but others as well, can be a very long process, long, slow decline, needing a lot of assistance, we have to look at that very carefully and say, how do we look at the other things that are going on also to help justify why we would bring somebody on in that time. A common question certainly for hospice is, well, do you get kicked off if you're still alive in 6 months? And the answer to that is no. As you probably mostly know, that it really is a much longer, if somebody is declining and we can still say, nope, they meet these criteria and these are the ways in which they continue to decline, then we can keep them on as long as we need to, as long as they meet those guidelines. Can they get kicked off? Yes, we've certainly had people, especially with dementia, who, they went to the hospital, they had a hospital stay for whatever reason, whether it was a urinary tract infection or a broken hip, they come out, they have significantly declined, right? Now they look like they're a 7C, meaning they're not walking, they're hardly talking. But once they're back in their own home and in their own routines, they rally right back out of that. And sometimes we take them off. People can graduate from hospice and they can come back on again at any time in the future when they meet those guidelines again. So that's just something to know. And that the good news, the bad news, I don't know, the ups and the downs, how it depends how you look at that, I guess. Um, so I know that I'm running close to the end of my time. Hope, I'm sorry. Is that okay if I go on for a few more minutes here?
You're great. I do want to just leave a few minutes too for questions. We had a couple
Okay.
pop in the chat box.
I think the other thing then, so kind of bringing it down to the short version here, is I want to talk about what kinds of things people die of with dementia, because that's a very common question that I get. And that, we think, well, if it's just about the brain is not working as well and now we need assistance with everything, well, we can keep doing that for a very long time. And we do see that excellent caregivers can really do an amazing job of keeping people's bodies functioning well. But as I was saying earlier, there tends to come a time when people just continue to lose weight no matter what you do, and then are no longer able to swallow adequately. And then of course their nutritional intake goes down as well. And so poor nutrition, weight loss, and ultimately just all the things that go along with that can be one of the ways in which people die from dementia. Of course, any number of things that could happen to any of the rest of us can also happen to somebody with dementia, even at the end, right? My mother-in-law, for example, who did not have really end-stage dementia, had a stroke, and that's what took her down, and she died as a result of that. Certainly broken bones. The statistics around people who have hip fractures and then have a rapid decline as a result of that, very common, more so with people who have dementia. But that doesn't necessarily mean that that's the case. I've seen many a person who we thought, oh, this is going to be it now. They went to the hospital, they had their hip repaired, they came back and we thought, okay, 6 months for sure. No, rallied right out of that, kept right on walking. And so you just don't know always. But that's certainly one of the things that can contribute to that. Any kind of infection certainly can do that, whether that's an aspiration pneumonia because they weren't able to swallow well, went down wrong, they got a pneumonia, we didn't catch it soon enough, or sometimes even if we did try and treat it, we weren't able to treat it adequately. Sometimes things as simple as a urinary tract infection, right, can become septic. They can just decline so quickly that becomes the thing that ultimately takes them. So those are just some of the ways in which people can die of dementia, not necessarily specifically the dementia, but the result of the things that are happening within the body because of the dementia. Yeah, I think I'll leave it there. I see, I had a couple more notes here. Let me just see if there's anything else compelling. No, I think let me leave it there. I think hopefully you've heard that there are definitely some upsides to, coming on to hospice, and some, of course, downsides to the end stages of dementia. But yeah, let me leave it there, see what you have.
Yeah, and there's some great questions that popped up in the chat box. The first question was just in reference to funding resources, specifically to Medicare, and Yuda was able to address that question. But in general, what would some funding resources for hospice be, even outside of Medicare?
So the beautiful thing is that really if you have insurance, almost all insurances cover hospice in one form or another. If you really don't have insurance and somebody is indigent and they don't have means to pay for hospice, then most hospices have a way to bring people on in sort of as a free service, basically. So that can happen also in a somewhat limited basis. People can pay for hospice out of pocket. Different hospices do that differently. They can do it as a per diem, per visit kind of way. So there are a variety of ways that can look in terms of that. But again, most of the time it can be covered through some means of through the hospice or mostly the insurances.
Thank you so much. The other question was looking at specifically in Santa Fe, an offering of palliative care. So
Yes,
kind of
thank
that
you.
pre-hospice pathway.
Yeah, the reason I didn't talk about it more is because, well, there's a lot to say about hospice specifically, but and also interestingly enough, palliative care tends to address some of the other diseases more effectively, I think, than they do dementia. But palliative care is really um, it addresses the issues that anybody facing a life-limiting illness may be dealing with. They deal with not, really trying to help negotiate the conversations that need to happen about where do we go next. It's most classically sort of in a, if somebody has been diagnosed with cancer and they get the opportunity to have a palliative care team working with them, and that can be in the hospital, in a clinic setting, or out in the community. We're lucky enough to have Janet Smith, who does community-based palliative care. Then a lot of times it's about having the conversations about, does whatever is being offered meet my personal goals? So the beauty of palliative care and hospice in that sense is that it really addresses what the goals of the person who are, in the position of having to deal with the patient themselves. It's not about, as it so often becomes in medicine, right? You have to do this and then you should do that, and now you need to do that. And instead it reflects what's important to me. If my goal is to be able to travel to another country and not do chemotherapy, how do I make that okay in the Western world? Well, palliative care really stands in support of you as an individual, us all as individuals, speaking from what's important to us. And that's part of what's so novel about palliative care and hospice in that sense. Again, part of what I think why we should be using hospice as our, or palliative care in that sense, as our model.
Person-directed care all the way. So the other question is the 7-stage model used for all people with dementia when determining the appropriateness of hospice. Is that stage used for all people in determining the stages or determining the need for hospice? Or is it a model that's random, or are there other models?
There are other models, and there are other ways of using prognostication for a variety of things. We also use, for example, a palliative performance scale, sort of tells you also about how able are you to manage things in your life. Are you still, up and about? Are you able to cook your own food? Things like that. Karnofsky scale, and any number of other ones that I think are not as popular, and I don't know, maybe as just as well validated, but just haven't been used as much. So it just happens to be that the way Medicare is currently, that's the one they've sort of focused on. And yeah, so there you go.
Okay. And then we do have a question, Dr. Thron, if you could talk a bit about pain management in hospice.
Oh, absolutely. Thank you for asking. Gosh, I think, palliative care specialists are really the people who that's their goal is to manage symptoms, and hospice even more so in that sense. And we look at pain management as a primary goal, right? If that is what somebody wants. So we use a lot of tools that many primary care doctors, for example, don't feel comfortable with, especially in this opioid crisis time that we live in. It is very challenging for a lot of primary care people to feel as comfortable prescribing the level of medicines that some people need towards the end of life. And so we have this sort of as our specialty area, and we feel like, generally speaking, we do it quite well. And so we use a lot of not just the opioids, certainly, but a lot of adjunctive, other kinds of medicines and other tools to try and help somebody to be as comfortable as possible at the end of life. I mentioned on Monday that, interestingly enough, pain is less of an issue, generally speaking, for somebody who is declining with dementia than with many of the other illnesses. But we do use that, and of course, for anybody, whether they have dementia or not, that pain is a primary issue for us, and we take that very seriously. If you have specific questions about that, I'm glad to answer that.
Oh, wonderful. And then we have one more question, and we still have about 9 minutes remaining. Will you address the tendency to wait too long to bring in hospice?
Yeah. Yeah, hospice, even though it's really aimed at hospice being present in somebody's life for the last 6 months and maybe a little longer, or sometimes quite a bit longer, but in reality, it gets used such that our average length of stay in hospice is about 2 to 3 weeks, depending on where in the country you are. And now in COVID times, honestly, it's been more like a few days. And I think that, of course, this has been a very difficult time, but at best of times, I think, so much of the conversation is about why are we not making better use of this incredible possibility? So much of it is because of what's in people's minds about that, right? You have to get to the place where you accept that somebody is actively declining or dying. And that's a challenge for a lot of families. Although some people can wrap their brains around what we sometimes present, which is that we are an extra set of eyes and an extra set of hands in the home because we know that they're appropriate for hospice and that they're really dying. And if we have to engage that conversation for a lot longer, we can start from that place, which says, okay, we don't have to talk about hospice yet. I mean, we have to in a way, of course, because we have to do the initial intake based on that, but we don't have to, it doesn't have to be all about dying initially, because it's all about living really in the presence of knowing that death is coming. So I think it's so much of it is about how people try and wrap their brain around it. In dementia or even in other things, it's a lot about, understanding not just that the time is coming, but when is the right time to say yes to hospice. So, because as you hear, if you have to meet a 7A criteria consistently, you have good days and you have bad days. And when the family says, oh, but she had such a good day yesterday, well, we won't call hospice that day, right? And so it goes. So there are some challenges just in terms of timing and really understanding that if we come on earlier, we can really bring so much more benefit on all the levels that we have to offer for the whole family, for all those involved. So.
Absolutely. Thank you so much, Dr. Thron. And just something that came to my mind as you were speaking at the end here is how many people actually graduate from hospice, possibly because they are taken from that mainstream medical model, and you're able to look more closely at their medications and their daily routines and their daily resources. And, it really is walking hand in hand with life and death because they are partners.
Yeah.
And so thank you so much. I do have one question, and this might take more time than our 5 minutes. So I don't know exactly how you want to address it, but it's a good question. And I apologize, I didn't mention names as we went along with the questions that were presented in the chat box to make it a community effort because we're all here together. But Sally did mention just the use of cannabis. And that as far as pain management, even psychosomatic pain. And what are your thoughts on that?
Yes. I am a huge advocate for anything that works, we should use, right? And because now it's cannabis, and I have seen it work amazingly well for people. I have also seen where it didn't work for them, but that's okay. I'm glad to try it. So I write for people to have their cannabis cards every day. I have 90-year-old women who are like, really, will that help me? Okay, sign me up. And so why not, right? If we have something available to us that can help somebody to find comfort at the end of life, I am all for it. In the future, it'll be much more about other kinds of things too, psychedelics probably. I know that's very much up and coming and will be more so. So I look forward to really anything that I can offer my patients in a safe, right? I don't want it to make it worse, but I certainly want to be able to offer them what they need or want in order to be able to make things as good as possible so they can really enjoy their lives for the time they have. Jutta, did you have something else?
Yeah, I just want to add something. Years and years ago, I met a group of gerontologists. It was psychiatrists who specialized actually of end of life at any age, and one of them would put give his patients not cannabis but ecstasy, and take them to Magic Mountain and ride the roller coaster, and so they could scream their heads off. And he said it was absolutely amazing because it allowed everybody to come back together and really talk about the whole dying process and accepting it. I said, it's okay. He said it was such a relief.
Yeah, so I think, right?
They're actually going back to re-looking at that seriously again.
Well, and there's a lot of research being done now with psychedelics at the end of life. So I actually look forward to what that's going to bring for us. Yeah.
Right.
Did that address that? I believe so. Yeah. Thank you so much. Yeah, the future is bright in life and death.
Yeah.
So And that's not to take away the hardship of either. But I do want to just check in with everybody. Anything from the audience, participants, in regards to additional questions before we wrap up this session? We do have a big thank you from Pamela. You're a peach, Dr. Thron.
I don't generally think of myself that way, but thank you.
I don't know you that way either. Thank you.
Yeah,
Dr.
definitely on the top 3 doctors list.
Thanks, Ruth.
And we also have that they have legalized mushrooms in Oregon for this purpose, also depression treatment. Absolutely. Psilocybin is getting a lot of recognition. It's in the news. It's being researched nationally and internationally.
We have folks here in Santa Fe who are doing research on it too. I don't know exactly where they're at and what's coming out of it, but I know that we have folks here too.
Yeah, absolutely. It just shows the openness to recovery and ability and the journey. So yeah, anything else? I think we're good. Last words were, why not? That was Timothy Leary's last words. Thanks so much.
I'll go with that as last words.
Absolutely.
Thank you.
Thank you so much, Dr. Thron. It was so good to be here with you today.
Thanks.